Thanks for joining us this morning for the latest installment in the Virtual Access series from the Downtown Seattle Association. My name is Felix Bonnell. Today we are going deep on one of the most troubling crises affecting a broad swath of the population in the United States, which of course includes King County and Seattle. The public health emergency with fentanyl at its roots has led to previously unimagined numbers of deaths in communities around the country and here at home. Along with the tragic loss of life, the crisis has sapped the human and fiscal resources of social service agencies, community nonprofits, and law enforcement, and done real harm to family-owned local businesses and big corporations at a time when everyone's looking to move beyond the struggles of the COVID era. Questions about fentanyl and about solutions to the crisis often draw a familiar answer from public officials and pundits. It's complicated. And it is complicated, but that doesn't mean that we can't all do more to better inform ourselves and each play our small part in a complex solution to complicated and a deadly crisis. Now, with this goal in mind of being more informed, DSA staff have done an excellent job to recruit a knowledgeable panel for our conversation today to address fentanyl, Seattle's public health emergency. Dr. Banta-Green is director of the UW Center for Community Engaged Drug Education, Epidemiology, and Research. He's also a research professor in the schools of medicine and public health at the UW. He conducts research, epidemiology, and implementation support for evidence-based interventions across Washington state. Dr. Banta-Green is also involved in policy at the federal, state, and local levels and was the senior science advisor to the director of White House Drug Policy Office in 2012. Dr. Cyn Kotarski is a medical director of Purpose, Dignity Action, formerly the Public Defender Association, and medical director of CoLead. Dr. Kotarski is a naturopathic physician who has served as medical director for PDA and as medical provider for CoLead since spring 2020. She testified in early 2023 on mental health and substance use disorder before the Senate Appropriations Committee, chaired by Senator Patty Murray. Dr. Kotarski has also testified on the topic before the city's Public Safety and Human Services Committee. Our third panelist is Daniel Malone, who became executive director of the Downtown Emergency Services Center in 2015. The center is a nonprofit organization dedicated to helping people who are most marginalized find homes, health, and community. It was founded in 1979 as an emergency shelter for vulnerable homeless men and women living with mental illness, substance use disorders, and other disabilities. Now, we'll get to our conversation in a moment. We have questions we prepared in advance, and we like to get to audience questions too throughout the whole hour. So if you go to the chat function and post your questions there, we'll respond to those and work those into the conversation as we move through the hour. We monitor those and keep an eye on those. And usually before we begin any of these virtual access conversations, we start with a few data points. So these come from various sources and were compiled by DSA. So far this year, there have been 936 overdose deaths in King County, the majority of which were in Seattle. 800 of those deaths involved opioids, and 95% of those involved fentanyl. Here's some more comparative data from January through August of this year. King County EMS has responded to 5,645 overdoses. That means they're on pace to go well beyond 2022's total count of 5,800. The Seattle Fire Department just reported it has responded to 4,000 overdoses this year. That's already 300 more than all of 2022. And the MIDS downtown ambassador teams have provided or administered Narcan 405 times from July 2022 to July 2023. All right, so those are our data points to begin the conversation with. I do encourage you, people in the audience, send your questions, post your questions on the chat function. Now, I want to start with Banta-Green from the UW Center for Community Engaged Drug Education, Epidemiology, and Research with a fundamental question, or essentially a request, and that is to properly name this crisis and define it. Dr. Banta-Green?
Thank you for having me, and thanks for hosting this, and thank you everybody for being here. This is just such an important topic, and we need exactly this. We need more conversation and understanding. So what we're really talking about are emergencies around both overdose and untreated opioid use disorder. And overdose, as you just said, is in some ways fairly straightforward to understand. And what people need to know is basically how to recognize and respond to an overdose. And so there are things that the educational materials, we have a webpage, stopoverdose.org, where people can learn how to recognize and respond to an overdose and how to use rescue medication, just as you were indicating. And That's a very, very, very essential and life-saving response that we can have. But it also is important to know that that is definitely insufficient. There's very strong public health research that shows that widespread distribution of Narcan or naloxone has about a 5% reduction in mortality at the population level. That is absolutely worth it. We should definitely do that, but that is not the solution by itself. We also need to really understand about opioid use disorder or addiction. And I would encourage you to think about the word disorder, which is part of what we're talking about, and probably why we're talking about it today is that word disorder. So opioid use disorder is three things. It's biological, it's psychological, and it's social. And the biological piece involves dependence and withdrawal. If any of us take opioids every day for a month, we're going to become tolerant. We're going to need more to get the same effect. And if we stop suddenly, we'll go into withdrawal. And I think what's important to understand is withdrawal feels terrible. It isn't just annoying. It feels terrible. Think about the worst flu you ever had and how much you really felt good sleeping on that cold bathroom floor to get that relief. It's about feeling that bad that you just are close to feeling like you're going to die. And that's what you're trying to avoid. So there's this biological piece that's happening. With that is a psychological piece. And that is a preoccupation with thinking about opioids all the time and craving, and an actual change in the biochemical reward system in your brain, where the drug becomes more important than food and love and water. And it's not a preference. That's not a choice. It's actually biological. It's a change in biochemistry, primarily in the endorphin system. And so you imagine if you have that physical dependence, you have to use, you're going to withdrawal. You have a craving and a preoccupation or reprioritization of your life around the drug. It's going to have profound social impacts. It's going to impact your relationships with loved ones, with your community, your ability to go to work, the ability to hold down a job. And that manifests itself as disorder and often chaos, both within a person and within a community. And so we're incredibly fortunate that the most treatable substance use disorder out there is opioid use disorder. We have incredibly effective treatments. The most effective treatments are the medications methadone and buprenorphine. And those medications get a person off of the biological roller coaster and get them just to a steady state in their life so they can then deal with the social and psychological components of their life, often having to rebuild those components. And those medications support long-term recovery, and they reduce mortality by way over 50%, and they reduce disorder, again, in that person's life and in the community. So that's a long answer. It is somewhat complex, but if you understand that, you understand that just telling a person not to use or just punishing them does nothing. In fact, it actually exacerbates the problem. You have to actually treat the underlying health condition.
Let me ask you a couple of questions about something you said. That notion of Narcan and the 5% mortality. Explain that for someone who just doesn't understand. What does that actually mean? What does that translate into, that 5% rate? What does that mean?
Sure. The idea is that many overdoses happen very quickly with fentanyl. It's highly potent. And the person may, even if you were there at the time of an overdose, you'd have to be there at a very quick interval to see that overdose. With heroin, overdoses often happened over an hour or two or three, and you would see a person going to sleep, turning blue, snoring oddly. The window of opportunity to intervene was huge. When I worked in DC in 2012 on the president's drug strategy on Narcan, it was a different world, because it was the world of heroin and pharmaceutical opioids, which are lower potency and a stronger and a longer duration of effect. So you have a curve that looks kind of like that with heroin or morphine or oxycodone in terms of the time of onset and a peak dose. With fentanyl, looks like that. So your window of opportunity to intervene is much, much shorter. So that's what we're talking about, is that It's just hard to intervene. You know, in a hospital setting, it's very different. In the real world, is the overdose observed, and can a person respond quickly enough?
So as a wonder drug, Narcan for fentanyl on the street it's 5%. It's not. Is that what you're saying?
Yeah, but as you just said, 5% of 1,000 people is a lot. That's
no,
right? It's absolutely worth doing.
Absolutely.
But I encourage people to not feel like they're done with their work when they are carrying naloxone and aware of that. There's more to do. There's to understand the conditions of people and understand the reasons and motivations that they use. Getting rid of the drug doesn't cure the addiction. Addressing the reasons they use cures addiction.
Okay. And the other thing you said about this being the most treatable form of addiction, that sounds really encouraging. Drill a little deeper down on what that actually means.
Well, sure. I mean, so Dr. Kotarski could speak to this really well. Also, I hope she will. Is that, you know, what we're talking about is a person being on a roller coaster and getting them to just a steady state of normalcy, And that can happen with treatment medications within hours to a day. Very, very rapidly, you see a person can return back to normal functioning. And so that, again, that supports recovery. So one thing I think is very important, and we have it on the back of our medications for opioid use disorder brochure, is that you can be on medications and be in recovery. That's incredibly important for people to understand. Most people don't understand that. They think you're swapping one drug or one addiction for another. But what we're trying to treat is the disorder or the chaos. I don't care if a person's on an opioid or not. That's uninteresting to me. What's interesting to me is are they out of chaos? Is their quality of life improved? Is their functioning improved? And that's really important because most people don't have a good understanding of what opioid use disorder is. And if you can deal with the biological piece with the medications, which we can, you can return so much functioning so quickly. It's not magical in and of itself. If a person is unhoused, that's going to be essential to address as well. That is a highly traumatizing, every day, every minute impact on a person's life, and a reason to use and feel escape, right? So we need to be thinking about that as just one of the drivers.
Okay. Now I want to ask all of you in a moment about the sort of status of the general community's approach to addressing the fentanyl crisis. But you mentioned Dr. Kotarski and this notion of the most treatable aspect of this. Is there something you can add to that? What Dr. Banta-Green was saying?
I would just emphasize, I think he said it very well, that we can use the medications, but if we don't work with people to help with, as you mentioned, homelessness or other situations that they may be in that may actually be the driving force for using the substances, they may still need to use something regardless of being on the medication. And so we have to make sure that we are addressing all social determinants of health for each person.
Okay. All right. In terms of the community effort to address the fentanyl crisis in the big picture, Daniel Malone, Downtown Emergency Service Center, why don't you take the first crack at that?
Thanks a lot, Felix, and really big thank you to DSA for holding this forum. And I also want to make note of one of the things you said in the intro, Felix, with some of the data points that DSA had compiled, that DSA's own safety ambassadors around downtown are administering naloxone more than once a day, literally saving lives downtown. And I think that's an amazing testament to DSA's work overall and adjustment to this crisis. We have a very similar experience at DSC. We have a couple of dozen different sites around the city. Many of those are permanent supportive housing buildings where people live in apartments. Some of them are shelters or emergency housing. Some of them are crisis centers, and some of them are outpatient behavioral health clinics. All of them, however, are focused on serving folks who have pretty complicated conditions, quite often serious mental illness, quite often long-standing chaotic substance use issues. And we've seen a huge shift in the last 1 to 2 years in particular. It's really escalated, but over a period of time, we've seen a shift in the substance that is being used by people. So I don't know if there's a significant change in substance use overall, but the substances that are in the drug supply are fentanyl involved. And in some cases, fentanyl is a substance people are looking for to use. In other cases, fentanyl is within the supply of other drugs like methamphetamine or cocaine that people are looking to use. And because of the things that Caleb was describing, the potency of it, we're now seeing far more medical emergencies with people doing substance use than we used to see. And in our case at DSC, we began to do an agency-wide overdose prevention and response program around 7 years ago. We adopted use of naloxone, trained all of our staff, and began supplying naloxone across all of our locations because there had been a rise in heroin use among the population that we see across our organization. And as we started to do that, our staff ended up being involved in overdose reversals about once a month on average. Today, our involvement in overdose reversals is about once a day on average across all the different sites. Sometimes that's people actually outside one of our facilities and somebody bangs on the door saying that help is needed. Sometimes it's somebody inside the facility. But I just say all that to illustrate how overwhelming it all is. And one note I will make about it is that the act of doing an overdose reversal, of administering naloxone to somebody and actually seeing them, revive from perhaps being blue or, clearly not breathing, is an amazing act that people are performing. DSA's ambassadors are performing, DSC social service staff are performing, of course, EMS medics and police officers and regular people in the community. All of these overdose reversals that are being done are really amazing acts of life-saving that are happening, but they are stressful as hell on people. And the more we put people in the position to have to do those acts, the more straining and stressful the work becomes overall. So I think just that rise in medical emergency from the change in the drug supply has brought us to a place where not only are far more people dying, but also far more people are having the medical emergencies that they're not dying from, but it is producing a tremendous amount of strain on everybody involved. And it's a really difficult situation.
So it's like an unquantified human toll on the caregivers or the people with social service agencies that, I haven't really heard that tallied or mentioned much at all, if at all.
I can imagine. Yeah.
Go ahead.
Well, just what you said, an unquantified toll on people. I think that's a really apt way to say it. We don't know the exact effects of it, but we know that people burn out doing this kind of work, and I think this is clearly a contributor to that.
Yeah, I think what you're saying is, and I don't think it's not some great leap to say that fentanyl changed everything. I mean, prior to fentanyl, your organization was dealing with heroin and other addictive substances, but fentanyl made everything just like that much more intense and became much more life and death.
That's exactly it. I mean, plenty of challenge from substance use prior to the rise of fentanyl in the drug supply. Really difficult and ongoing situations. A lot of progress made on an individual basis with folks, but still a really large amount of, just addiction among this high needs population group. And that was always challenging to deal with. You layer on top of that people are literally dying or nearly dying, and it takes it to a whole new level.
Dr. Banta-Green, is there a way to characterize or sort of summarize what is the community's response to fentanyl currently? What are we actually doing? Who's involved? Kind of give me the lay of the land of the battlefield.
Sure. So, there are things happening on multiple fronts, and a lot of things have sort of been piloted in Seattle and are beginning to be replicated across the state. In 2010, Washington State passed a Good Samaritan and overdose and naloxone law. So that's really when naloxone became more widespread. And the Good Samaritan component of that is that a person who has an overdose or responds to an overdose cannot be prosecuted for drug possession. So that's just important for people to know. We want people to respond. And then in 2017, at 4th and Blanchard at the Downtown Syringe Services Program, we launched a program called Buprenorphine Pathways. So buprenorphine being an opiate addiction treatment medication. The idea was that I've been doing research around the state and found out that 80% of people with who were injecting opioids wanted to stop or reduce their use. They wanted to stop or reduce their use. Most wouldn't go to traditional healthcare locations because they couldn't deal with the navigation and appointments and or how they were treated in terms of the stigma around having substance use disorder. So most wanted to stop or reduce use. Most weren't willing to go to traditional healthcare systems, but most were at the Syringe Services Program. So that was sort of peanut butter meets chocolate, or buprenorphine meets the Syringe Services Program. So we launched that program at 4th and Blanchard. And within a couple of months, people were lining up 2 hours before the clinic opened for sort of free drop-in access to treatment medications. So the idea that people don't want treatment is not correct. It's just not correct. And so if you build it, they will come. And we've been scaling that up across Seattle. DSA does this work. PDA does this work with some of their partner organizations. And I've been working with an Allen Foundation grant to replicate and test this across the state. And it's now also baked into state legislation with a community health engagement model. One of which we're looking at with a NIH grant that I have, hopefully in partnership with DSA soon, to launch an opioid recovery center with also the ability to have drop-in access to not just treatment medications, but also harm reduction services and supplies, and also a place that FIRE can divert people to, either people who don't really need to go to ED, but we have nowhere else to send them, or who we're leaving in the field who clearly aren't doing well, but we want some place to care for them on a drop-in basis. So it's been a very busy 8-10 years. We really are doing a lot. The issue is we probably still have a 70 to 80% treatment gap. We still have a lot more work to do. And part of this also ties into the crisis care levy as well, is building in the same amount of capacity for drop-in access to care. I know too many parents who have kids who've died while waiting to get started on treatment medications. And that's insane. This is a life-threatening condition, and you shouldn't be waiting weeks or months to get treatment.
I want to hear more about the overdose treatment center. I know that's on the horizon. What currently happens, or what's the current protocol if someone is revived with Narcan from an overdose and they're on the sidewalk? Do they have to go some certain place, or what happens next? Is that Dr. Kotarski? Is that something you want to answer?
Sure. Well, they don't have to go anywhere because medical treatment is voluntary. And so, post overdose, I can speak for sort of the way that we do this in my org. Our staff would always call EMS, always call 911 during an overdose, which everyone should do. It is part of what to do when administering Narcan. Because even if the Narcan works, we don't know what else could be at play. And we may need the EMS staff on site to be able to help and support. But if the person does revive and is conscious and is stable enough to decline to go to hospital for additional follow-up or treatment, they can decline. So that is the state where we are right now. Some people will accept and they may go. But even if they do go, hospitals are designed, they're like, the whole point of an emergency room is to save a life, right? So once they establish that somebody is stable and not in that acute risk of survival, then they will be discharged. So once they are discharged, then we are kind of back to where we started with regards to the barriers to access care, which I can speak about a little bit more, but the barriers to access care for that longer term treatment, but also, and critically, they are in a very vulnerable state because post overdose, if they do return back to the environment that they were in, not only may they have a physical want or need to use the substance again because they will have experience some withdrawal symptoms, but they're also in a window of time where the risk of overdosing again is greater.
So are there legal tools or procedural tools or other sorts of tool, and I'd say tools, I mean laws or changes in the system that would make your organization's work easier, or any organization's work easier, to intervene with somebody in the immediate aftermath of surviving an overdose?
Sure. So I think one of the first things, because it's one of the only tools that we have right now, one of the first things that gets thought of is involuntary treatment, right? So holding someone and a civil commitment, even if they are not going to do that, there's a process that can happen. And, Ricky's Law was passed in 2016 and really started becoming implemented in 2018 in order to hold someone. Again, it's a whole system that does need a process that needs to occur, but that somebody can be held for substance use. That's the difference with Ricky's Law. Prior to that, it was mental health crisis only and not specifically including substance use. The problems there are a few different things. One, the person really would need to be assessed by a designated crisis responder and would need to meet the criteria for that civil commitment, which is a pretty high bar to meet. It's not just an overdose. That would not necessarily be enough to meet that criteria, because it's really designed for someone who is essentially a threat to themselves or others or grave disability. Yeah, so one, we don't necessarily have enough DCRs to do these assessments, but then also right now we don't have enough beds to place people in. We have a very limited number of beds, and they are maxed. Pretty much all the time they're maxed. So that really limits the ability for them to get that care. Lastly, that is it's a last resort option. It's for people, a small percentage of people who meet that criteria, and that's the only option we have to keep them safe in that time. And it doesn't apply to the majority of people who are experiencing an overdose or substance use disorder. For that small subset, though, when they do receive, if they do receive that ITA, some of the issues that we're finding, even if we do it, is they will sometimes be discharged to basically what we've just described before, to the chaos again, unfortunately. So if they're discharged back to street, if they don't have a care plan in place that meets their needs, we're putting them right back in the same situation. And same as I said about hospital, they now have no tolerance. So their overdose risk is actually higher at that point in time, even if they even if they did use in a way that they have used before, that could be too much for them and could cause them to overdose again. And then the last thing that I'll just note is we know, I mean, we have seen through research that compelled treatment, it doesn't work well. Enforcing treatment does not work well for long-term recovery, and that we really need to work with people for them to voluntarily seek treatment for their own intrinsic motivation, for reasons that matter to them, in order to take that recovery pathway and reduce the likelihood of relapse.
I think just to follow on, I think we do want to protect people. We see people in danger, and we want to protect them. And I understand that instinct. I feel the same thing as well. And if we had the capacity for permanent supportive housing with intensive, healthcare, behavioral health, and treatment services, and we could help support people in that would be wonderful. And I hope we will get to that. In the meantime, the reason I was mentioning buprenorphine pathways is that it doesn't have to be coercive. If you build it, they will come. And not everybody, but a large majority of people will come, and really saving that involuntary treatment for the margins. And again, there's so many processes there. So I think rather than, it's an understandable instinct to want to protect and mandate treatment. And we all can think about anecdotes and people for whom it worked. Oh, that was the thing I needed. I needed to go to jail to get my wake-up call. And then when you ask them, well, would housing and healthcare have done the same thing? Oh, sure, but that wasn't available. All that was available was incarceration. Yeah. I just think that's important to keep in the mix.
I think that's a communications battle. I think that anecdotal sense of whether mandatory treatment works or not seems to be just have taken hold. It's an easy debate for anyone who's uninformed to get into, or who has just some maybe immediate personal experience or some secondhand knowledge or something. So I think that message is really critical. I think we heard some of that in the debate in the city council the other day over the ordinance that was recently passed. Now would be a good time. Dr. Banta-Green, can you speak to this ordinance that was just passed by the city council that's awaiting executive action for some specifics around law enforcement? Can you speak to that and that's impact on the work you guys are trying to do?
I'll take my stab at it. I also think our other panelists would be great.
Of course.
So, the idea here is that, Washington State, within Gross Senate Bill 5536, made drug possession and use a gross misdemeanor, which is up to 364 days of incarceration. There was a committee, the State Substance Use Recovery Services Advisory Committee that it was on, that recommended that it be made a misdemeanor with no incarceration because of the risk and the counterproductive nature of incarceration. So I want to say that the state committee that was asked by the legislature about what to do about the law did not recommend gross misdemeanor at all. So that's important to understand. That is what the city council passed yesterday. And that also includes the ability to arrest people for public use, including if that, I think in there, I believe the final language, I haven't read the final language, but I know it's part of the conversation, if they are a risk to others, which is more than a little nebulous. I think the real concern about that is one, they all say we want to send folks to treatment, but they're not creating the funds for this 80% treatment gap. So that's pretty essential. They're saying, well, we're going to create this law enforcement response, but we haven't created the compensatory response to what they say they want to do, which is refer people to treatment. So that's super important. The other issue is if you further penalize substance use, is difficult. I mean, I work in the university district and I walk to work. I see people using fentanyl every day. And I occasionally have to check on people and make sure they're okay. Like it is a difficult time out there. I get it. And yet, I would rather be able to see that person and check on them. But if they know that that public drug use can lead to them being arrested, they're going to go somewhere where they can't be seen. And when they can't be seen, they're more likely to die alone. So there's some real consequences to this public drug use. That is not the intent. I get that. But they're pretty anticipatable, if that's a word, consequences. So I'm curious also, from other perspectives. I mean, Daniel's seeing folks, out and about in their community, works right downtown, just trying to think about the potential consequences of that law. I understand the intent, but it's not actually, it's not set up to succeed. I don't understand how it's set up to succeed.
It seems like there's a lot of intent, and it's the intent, it doesn't feel like it's all being woven together just in a comprehensive, cohesive, high altitude approach that lets us drop down to the lower altitudes with strategy. I don't quite see that all meshing together yet, unless I'm missing something. Daniel, do you want to respond to the question about the ordinance?
Well, just briefly, I do appreciate the motivation behind it, as I understand it, which is to intervene in making sure that people aren't just left to suffer and die on the streets. And the street environment is really rough. It's not good for anybody to have it out there. I do agree entirely with the statements Caleb was making about we need to create the attractive treatment availability for people that is going to bring people into a much better way of living their lives. And one of the programs we operate at DSA is a buprenorphine medication for opioid use disorder treatment program. And we enroll about 15 people a month into that program. And it's, really helpful and important for those people who are coming into that program. It's delivered out of a facility that, isn't super attractive in terms of that's a place people want to go and participate in, getting onto care and so forth. And so some of the work right now is focused on creating this place that people are going to want to come to, a deliberate overdose recovery and treatment initiation facility where people can get a range of needs met, including care for an extended period of time, medical support for comfort, as well as starting on medications that, there can be a little bit of a bumpy ride as people are starting on some of those medications. And I think if we're successful in getting all of this created, we'll have the capacity to serve up to 20 people a day getting into treatment and starting on medication in a facility like that, as opposed to the current level we're getting to today, which is about 15 people a month, as I said. So there needs to be way more done to fill these gaps. We still have a huge gap in that so many of the people who are using on the streets, even if they begin treatment, don't have a place to go. They don't have what they need to stop the other aspects of chaos in their lives. And that's going to remain a huge headwind to progress here. And so we need to do all of these things in concert, create more places for people to be that they want to be in, and create treatment environments that people are going to want to come to.
And the overdose treatments, what's the actual official name for it's overdose treatment center, overdose recovery? Official name for it?
No official name yet.
Okay.
Still under discussion, but yeah, opioid recovery and treatment.
And when is that coming? When will we see? Where will it be? Give us the specifics about when and what to expect with that.
We have space in the second floor of the Morrison Hotel. We can build a really high quality behavioral health clinic that includes this dedicated opioid recovery and treatment center. The space is ready to be built out. King County Council has earmarked some funds. DSA has acquired some private funds for it. The city of Seattle has announced earlier this week that in November, they will have a funding competition for some funds that could be put to this use. So once those funds have been awarded and we've acquired enough resource, we'll be able to build out the center and open sometime next year. Probably the earliest it could happen would be in the middle of next year. Not entirely clear about all of that, not entirely clear if there's going to be enough money available from the city to cover the full costs of doing this. And then there's the matter of acquiring all the operating funds. Caleb's team and others at DSA are working very hard to identify what are the range of operating sources available to have a robust facility operating 24/7. So there's still a lot of unknowns, but there is the basis of what could be a really effective and helpful component of the system.
Okay. I mean, it seems to me, and I'm armchair quarterbacking this. It seems like we needed this yesterday or last week. I mean, we needed this
Totally.
a couple of years ago. And some of the questions from the audience are asking things like, there's already places for people to go for treatment, Weld Works, Oxford Housing, Battlefield Addiction. Someone says, why not invest more heavily in Evergreen Treatment Services on Airport Way? They're a huge player in this crisis. Can't believe they're being funded for a larger facility. So what's missing from the current places where people can get the kind of treatment we're talking about with this, specifically with this overdose recovery center?
Well, I mentioned a couple of things. So Evergreen Treatment Services is a partner in this. They've been part of the clinical design team. We've been meeting twice a month for over 6 months, and they're an active partner in that. And I actually did my training there in 1995. So if I have a conflict of interest, I guess it's that. Started working with them a long time ago. And they are actually really adapting their model of care to lower the barriers. And they are also moving to do more mobile work out in the community so people don't have to go all the way down to Airport Way. So Evergreen Treatment Services and other providers who are primarily using methadone as a treatment medication are definitely expanding across the city and across the county. And housing and things like Oxford Housing can be really helpful for some people, but they are not effective treatment for opioid use disorder. I'm going to say that point blank. If a person is allowed into Oxford Housing while they're on medications, which is up to the vote of the House, that can be a good supportive place. We absolutely need recovery housing, and we need different models of recovery housing for sure. But we also need to understand that Oxford Housing in and of itself is not treatment for opioid use disorder, and in fact can be counterproductive unless they allow people to be in there on medication. So we need a broad array of services. We need to allow people a full choice in their work. All of the work that we've been doing for about 8 years now is around taking what we call a shared decision-making model for care. That's a normal thing for surgery. That's a normal thing for depression treatment, that people have a voice in their care. But too often because of position in society, race, or class, people get one offer of treatment. And it's either this way or nothing else. And that's not okay. Different treatments work well for different people. They have to have options and choices, which we're also trying to build in.
Dr. Kotarski, do you want to add something?
Yeah, sure.
Yeah.
I was just, I agree with, there are wonderful orgs out there doing great work. I think, the idea of just give that one org more money and that will solve this is likely not going to work, because we're missing that strategic plan, that comprehensive overview and plan. And if we think of this as the epidemic that it is, and we know what to do with an epidemic. We just came through a pandemic. We do know what steps need to be taken, and we have to hit all the marks. If we don't hit all the marks, that's when the system, so like they named some housing places or some different clinics, they're going to be overrun because they're not designed to take every phase or stage of a plan. So right now, we know we need prevention, we need education, communication, and planning. So that's step one for, you know, any epidemic or anything really when you want to try to solve it. And then we need early detection, early intervention, and we can do this with already existing providers. We just need to make sure that we build it out and train them in order to do so, which is something that has been missing for various reasons. And then we need that acute care, like that crisis management moment. And we are really missing that. That's when people are talking about overdose recovery centers, crisis care centers. I think there's a misinterpretation that people can just go to the hospital. And the reality is, one, it's incredibly expensive to do that. And two, it's not the most trauma informed. Unfortunately, people experience a profound amount of stigma when trying to access services. And again, we could talk about the why, but that's a bigger conversation. And we need to do things in order to combat the stigma, but we're not there yet. It's pervasive. And when I say that, I mean to the point that hospitals are required to triage and treat. And we have seen examples where legally they're required and it doesn't happen. People are turned away. So when I think somebody on the call mentioned like attractive services, really we're talking about basic accessibility, to not be traumatized at attempting to access care and to get the level of care that's needed. So that's that missing piece, that OD recovery center, that crisis center. And then last, you know, we need that long-term management. Again, going back to the providers, like you're talking about ETS and Evergreen Treatment Services and addiction service providers, behavioral health homes, things like that. Absolutely, for that longer-term care and management. And then above all else, right now, what we really, really are missing is the bridging of the care, meaning that when somebody leaves one level of care, how do we ensure that they make it to that next step? So if you were to have a heart attack and go to hospital, the next step would be following up with your cardiologist.
Yeah.
We have to have that bridge. We don't have the level of discharge planning and coordination and support needed in order for those things to happen. So those are the gaps that people
So again, from sort of the armchair quarterback's perspective of, you know, someone like me, it seems like it's not a mystery what needs to be done. And if I'm a business owner in downtown Seattle trying to reopen my shop, or if I'm working downtown Seattle, or I live in King County, or I'm just compassionate and I worry about, you know, my neighbors and people in this community being sick and dying because of untreated opioid use disorder. And you know, just between you and me, what's taking so long? I don't want to blame. I mean, I don't want to point fingers and blame. Blame doesn't accomplish anything. What are the barriers? What's in the way for all this coming together at this comprehensive strategic level with the delivery of services at the level it's needed? What's stopping that from happening more quickly? Is it money? Is it politics? Is it ignorance? I mean, is there particular people? I mean, I don't think blaming anybody or pointing fingers at specific people necessarily accomplishes anything, but it seems like there's all these different pieces that just need to be, and I'm overstating the simplicity of it, obviously, reducing it down to oversimplifying it. But why is it taking so long? What's missing? Why if I'm out in the community, am I so frustrated that this hasn't happened sooner or hasn't happened yet?
I mean, I think for me as a medical provider, I do think that a big component of what you're describing is a lack of the planning from the medical side, from the medical and behavioral health side. We have a divide in medicine, in medical, considering physical medicine versus what we've lumped under quote unquote behavioral health, which is mental health and substance use disorder. And we sort of have this thing that happens with substance use disorder where each side sort of points to the other. So we have people who go in for behavioral health and for substance use, and they have physical ailments. So they're turned around and sent to for physical medical treatment. And then medical treatment says, this isn't what we do. This isn't our specialty. This isn't what we're trained to do. We need you to see somebody who is a addiction specialist, for example. So I think there's this, it's not mine to deal with is part of the problem. And again, I go back to just that comprehensive plan. It can't fall to the individual providers to create that plan. And right now, we know that this is an epidemic, but it's not being treated like
Yeah,
one.
didn't we all work together pretty well? I know on earlier panel discussions in this series for DSA, we talked about how effectively the barriers fell away in facing COVID in terms of getting people housed in individual not collective units, like individual units and everything, and really addressing the crisis. Just boom, without. Why is that not possible so far with fentanyl?
Yeah, I have some of the same questions. Are we just not scared enough of it, that it might affect us, across society, like we were with COVID, which allowed for really huge shifts to happen? I will say that, among people experiencing homelessness or other forms of marginalization, we were scared to death that COVID was going to sweep through and kill huge numbers of people. Before that was able to happen, there was massive action that happened and mobilized very quickly to make sure that we didn't have large crowded congregate shelters operating, and that people could be in spaces where they were going to be more protected from the spread of this thing happening. And I think a lot of lives were saved from those actions that so many people were involved in and so many different entities and governments were part of. Now the fentanyl crisis is doing what we feared COVID would. It's killing tons and tons of people among this population, and that kind of action that you're describing is not happening yet with it. And so it's already been mentioned that we need a comprehensive approach to creating all of this treatment and places for people to be and so forth for this current crisis of fentanyl. And I think we need all voices speaking and demanding that we have a comprehensive approach to that. I think it's really great that DSA, for example, is having this forum right now, because there's some influential voices among the DSA membership that can be powerful contributors to this demand for a comprehensive approach that needs to happen for this problem.
Have other cities
supply and demand? If you don't mind, it's
sure,
about
go ahead.
Supply and demand. I mean, we know what we have services that can be the supply. Dr. Kotarski talked about some medical things about how we can take that to scale and some barriers in a healthcare system. We are putting out a letter today, myself and other sponsors of the State Opioid Response Work Group, the other executive sponsors for National Overdose Awareness Day, that really talks about we need every single healthcare provider with a DEA license to care for people who have opioid use disorder using treatment medications. One of the barriers to that, and it is a barrier generally, is the misunderstanding around use disorder. And that is that people who use drugs. And they often use drugs while they get care. And sometimes they use drugs, typically at a much lower level, while they're working on their recovery and working through that. And that is something that many providers and many people in our community are very uncomfortable with. We see addiction and people use drugs as bad, and we see that it's binary. You need to be good or bad, and if you're not good, we're not going to care for you. We have to do away with that. We have to understand what use disorder is, and that it is a long process of recovery. And so that also means being comfortable with this grayness about caring for people, and that harm reduction has to be part of that continuum of care as well. So to the point, from a demand side, there's no win for politicians right now. There's no advocacy group that's well, there are advocacy groups, but they're not seen as legitimate. And often it's because they're people of color and people who are in a criminal legal system who are advocating for these issues because they're so differentially impacted by what's happening with illicit drugs. They're very marginalized, and we don't listen to them, and we want them to go away, is often what things look like. But what I'm saying is that I want a mobile medical van outside my work, outside my home, where the problems are. So we need to be demanding these services in our community. We need to have enough demand that there actually becomes political will, that politicians will actually act on it.
Yeah. Do people not respond to the cost argument, like the invest this much now instead of X times this later, or is that just not, that doesn't capture people's imagination? I know
there's been data out of the State Institute for Public Policy for over 20 years showing the cost effectiveness of treatment medications for opioid use disorder. It's not about evidence. Unfortunately, as a scientist, it has nothing to do with evidence. It has everything to do with political will. will.
Okay. And I know we wanted to get to at some point talk about other communities in the United States where they might be doing this better than we are here in Seattle, or that offer some kind of model we can follow. Are there particular cities we can point to that are approaching this in a way that we can envy?
So Boston has something that they just ran out of money for, which is called the Boston Roundhouse, which was a very similar model around an opioid recovery center at a permanent supportive housing building. So we've been working very closely with them and their medical staff to learn from their work over the last year about how to build this center here. So we're certainly working with them. San Francisco has been providing drop-in buprenorphine out of the county-run pharmacies for 15 years. So a lot of what we're doing, we're kind of learning from and adapting from some of these other cities. And then there's really tremendous harm reduction work that's being done. You know, naloxone really started in Chicago long ago. We were kind of a little late to that for sure. We're doing that. There's harm reduction work around drug checking, what's actually in the drug supply that's happening. So there are a lot of things out there. But I think fundamentally, I think there are issues around pure capacity for this visible homeless population that's using fentanyl. That really comes down to permanent supportive housing, an adequate amount of it, and enough funding to actually make it really supportive of the people that they're actually getting all of their care needs met.
And I mean, it seems like the money is there if the articulation is made clearly for what the ask is. What else is? I think I asked this before. Maybe you guys already answered this. But what's standing in the way of making progress on this faster? I mean, is there? I mean, it seems to me it's a communications issue. I bias toward communications and media and that sort of stuff, and I always feel like there's, a well-run lobbying campaign or public affairs strategy to reach the opinion leaders who make the decisions and hold the purse strings on this stuff. But that hasn't. It's been kind of.
It's not a sexy thing to talk about, but workforce is actually really, really, really important. Adequate nursing workforce, adequate medical workforce, adequate permanent supportive housing workforce, outreach. Like those are difficult things to staff up. It's very difficult, very traumatizing work, and it doesn't help that the work doesn't necessarily pay that well, and it's kind of looked down upon. Like the people who do that work also deal with some stigma as well, is that they're somehow perpetuating this crisis, which is not what they're doing. What they're working is trying to enable people to live and have improved quality of life. So there's a lot of pieces. It is quote unquote complicated, but I think it fundamentally comes down to ultimately this being a priority.
Right. One of the things also we talked about in our preparation call the other day, Dr. Kotarski, you mentioned this sort of, I don't know if necessarily unanticipated effect, but this long-term decline and like the long tail of the cost, the costs of caring for someone who has a opioid use disorder for some period of time might experience effects for a really long time. Can you talk a little bit about that?
Yeah, and we can't just take somebody out of their reality, their existence, with everything else that goes on. So, and what I mean by that is oftentimes opioid use disorder is overlapping many things. People living unsheltered have higher rates of physical trauma. They may have had head injuries. There's so many different components that can come into play. But ultimately, one of the things that we do see with fentanyl use is this potential for long-term cognitive impairment post-use, especially if there's high levels of fentanyl or repeated overdose. These things can point to it being a higher risk. So if we do wind up having people who have some level of long-term cognitive impairment, part of that long-term management plan is also, we talked about PSH for housing, but also looking at making sure that we are developing housing options for people that provide the level of care that they need. And some may be market rate, some may be PSH or permanent supportive housing that has some level of support. And what we're really lacking in is for folks who are going to need more of a skilled nursing or adult family home level of housing.
Yeah, I mean, this is a very complex issue, as we said at the start, and I think I feel like I've learned a lot today just talking to you guys, and there's obviously more we can do, and I hope we can continue this conversation in the future. We're almost out of time. Haven't been able to bring all the questions forward. Lots of great questions from the audience. I tried to hit the ones that fit the most into the narrative arc we were exploring here. I think it's in summing things up a little bit, I want to ask each of you in a moment to kind of give me something positive to think about, something to look forward to, some silver lining in the cloud or some ray of light on the horizon, because we like to end these conversations on something optimistic and positive. But it seems like, to sum things up a little bit, it's very complex. A lot of pieces are there. It needs more money. It needs political will. It needs advocates. It needs a lot of overcoming a lot of misconception in the community about what opioids do to people and what people are affected by opioids. And it seems like a massive educational campaign that would be, super helpful nationwide, not just in Seattle and King County, but it seems like there's a great opportunity for that. But so Dr. Banta-Green, let's start with you. Give us some ray of light in all the darkness here about what we're facing and what's ahead.
Yeah, the ray of light is we know what to do. We have the tools. We understand this. There's good science about what to do. And you have got people here. We have awareness growing right now. And so I would really encourage people to do something, including looking at the webpages, stopoverdose.org and learn about treatment.org, learn something new and share that with at least one person. We know what the tools are. We just need to build up the demand and awareness of them. So again, I really appreciate it and thank you for this opportunity.
Thank you. Daniel Malone from Downtown Emergency Service Center.
Thanks again for having me. Well, there is some momentum toward creating additional treatment facilities to fill some of these big treatment gaps that we currently have. So I feel good that, we're at least continuing to make progress down that road, even if it's not as fast as we need it to be.
All right. Dr. Kotarski?
Yeah, I think it's just similar to what both of you have already said. We can do this. We just have to decide that we're going to do it. We did something similar with how quickly we scaled up for COVID and how we came together. We created the strategic plan. We knew what we were going to do. We brought vaccines to market at rapid rates compared to previously any other vaccines that we have tried before. I really think that we can do this. It's just that we need to decide to do it, and then we need to work together to get it done.
Yeah, and people want to help. People want to be part of the solution. I guarantee that they do. I want to thank our panelists, Dr. Kayla Banta-Green of the UW Center for Community Engaged Drug Education, Epidemiology, and Research, Dr. Cyn Kotarski of PDA and co-lead, and Daniel Malone of the Downtown Emergency Service Center. And I want to thank you for joining us today on DSA Virtual Access. Appreciate all the great audience questions. I'm sorry we couldn't get to more of them. Thanks as always to the fabulous DSA staff, John Scholes, Sally Wright, James Cito, and Simon Villanueva. Just on a final note here, the past summer saw an incredible amount of economic activity in downtown Seattle with Taylor Swift and Ed Sheeran and their thousands of fans. And the Seahawks are back at Lumen Field this weekend. The Mariners still have a chance to not be quite done with the 2023 season. And as all that unfolds, and please plan on joining us again for the next episode of Virtual Access on Thursday, October 19th. Watch your inbox for more information about that. And until then, I'm Felix Bunnell on behalf of the Downtown Seattle Association, and we will see you downtown.